Mentioned I'm the first installment in the wellness series of grand rounds where the junior faculty give their grand rounds so everyone can get to know us a little bit better. And when poor Vicky was like, please send me your slides, the last 3 weeks, I said, wouldn't it be easier if I just like baked some cookies for you guys? We had an hour off, something like this for wellness. Anyway, I really appreciate the opportunity to present this morning, and bear with me. I included some background about myself, kind of how I have arrived to where I am today, just, so you can get to know me a little bit better. I had a picture of a robot on here, but Nico made fun of me yesterday, so I took it off. No disclosures for this talk. As Sean mentioned, I was born and raised in Northern Virginia in Fairfax, like solid suburbs of DC. I have 3 brothers. We're all about 2 years apart. I'm the second oldest. So this is my older brother, Andreas, my middle brother, Mikey, and my baby brother, Nico. And I would say my childhood was mostly characterized by like the chaos of being raised with 3 brothers and playing soccer. So I played soccer. That was kind of like I played at a pretty high level. It was like my main activity and my main defining part of myself growing up. And as a kid, I thought maybe I would want to be, actually I did want to be a veterinarian because I loved animals. I don't have any other physicians in my family, so I haven't really thought about human medicine. But anyway, I graduated from high school and went on to William & Mary, where I majored in biology, and I played soccer. And during college, actually, I worked at a veterinarian office over the summer, and that's when I realized there was like no way I could actually be a veterinarian because I could not handle seeing animals suffer. And I don't know what that says about me that I pivoted to human medicine, but here I am. And I graduated from William & Mary and then came straight over to UVA for medical school. And this picture is from our white coat ceremony on the lawn. I actually started out in the MD PhD program at UVA, but after doing my rotations through several basic science labs, kind of came to the realization that there was absolutely no way that I had the like motivation or probably skill set or desire to do a PhD in basic science. So I dropped out of the PhD portion of that and finished med school. And honestly, I had no idea what I wanted to go into when I came to med school. Again, like I mentioned, had no previous exposure really to medicine and wasn't sure what I was interested in. It was really during my 3rd year clerkship rotations that I got interested in surgery. And I'm sure many of you recognize this person. This is Dr. Rose Metzger. She was a chief surgery resident when I was a 3rd year medical student. She was my chief resident down at the VA when I did my clerkship rotation there. And I literally thought Rose was like the closest thing to a god. I thought that her ability to take care of sick patients and make decisions and operate was just so incredible. I really admired her, and I thought, like, well, if the pathway to being like Rose is general surgery residency, then I have to seriously think about this. And I still remember the day at the VA, we were doing like a pericardial window for something. I couldn't tell you what, any of the other clinical context there, but she's like, here, put your hand here. You're touching the heart. I went home that night, like told my mom and my brothers all about this. And then my other kind of medical school mentors were Dr. Friel. He was the medical student, like clerkship director at the time, and I rotated on the colorectal service. I worked with Dr. Hedrick and Dr. Friel, and, kind of furthered my interest in surgery. And then I did my sub-I on the MIS service and worked with Dr. Shermer very closely. And both of these guys were just really huge supporters and kind of gave me the confidence and belief that I could actually succeed in surgery. And I just have to share this email that I dug up. Hopefully Dr. Shermer doesn't mind too much. But so my 4th year, shortly before match, I went to this away rotation in Ghana, and I was trying to figure out what I should do for my rank list. And I really thought the general surgery residency here was phenomenal. And I knew the residents were so proud of the residency here and that I would get amazing training. And I already had such a positive experience, but I had been in Virginia my entire life. And I thought, this is the chance to kind of go live somewhere new. And so I decided I was going to rank Wisconsin #1. And I sent Dr. Shermer an email to this effect. And I'm like over in Ghana commiserating or like, you know, being tormented by this decision. My favorite part here. So he tells me the grass in Wisconsin, don't forget, is under snow, may not always be greener. So nonetheless, he was incredibly supportive, and I did go on to Wisconsin for my general surgery residency. And lo and behold, he was not wrong. 6 months of the year, Wisconsin is covered in snow, but I kind of embraced it. I took up cross-country skiing, got my like big puffy coat, and you know, I loved Madison. I actually fell in love with Madison. Really got good training in Wisconsin, and during residency, I did 2 years of research with one of the colorectal surgeons there, doing outcomes research in clinical investigation. I like designed and did this like pretty rudimentary randomized controlled trial on using Flomax for prevention of post-op urinary retention. But got really good experience there. This guy, which many of you probably recognize, was one of my primary mentors. Chip Foley used to work here as a colorectal surgeon. He was my program director in Wisconsin and was, you know, just truly the epitome of a professional and a teacher, really a phenomenal teacher. So I actually thought about going into colorectal surgery. I thought about MIS. I thought about surgeon. Ultimately, I was very drawn to transplant. I loved the operations. I thought they were incredible operations. I enjoyed the complexity of it. I really enjoyed doing open surgery. I enjoyed the team nature of transplant and how life-changing it was, how grateful the patients were. So ultimately, I decided to go into transplant surgery, and I stayed at Wisconsin for my fellowship. Wisconsin, you know, does liver, kidney, and pancreas transplant, so I got pretty broad general transplant training there. You know, I'd say we do a lot of living donor kidney transplant. It's one of the highest volume pancreas transplant programs in the country as well. So really good experience there. We did all of our donor nephrectomies. This is me doing a laparoscopic donor nephrectomy with one of my attendings. We did them all laparoscopic in Wisconsin, so pure laparoscopic. And I got zero robotic experience, so I'll talk about that a little bit later. This bottom row of pictures kind of like, I feel like really captures the essence of transplant surgery fellowship. But I will say, that aside, for anyone thinking of transplant fellowship, this was genuinely 2 of the best years of my life. I really, really had an amazing time and got good training, and I'm glad I chose this field. So after fellowship, I went to the University of Cincinnati. I practiced there for a year, and then when the opportunity at UVA came up, it was hard to pass up. You know, it was an opportunity to come back to Charlottesville and be part of a really great program, learn robotics, be more involved in liver, stuff like this. So now here I am at UVA. I don't know, I probably like spend about 60% of my clinical time doing kidney, maybe 40% doing liver, a little bit of pancreas. I do all of our donor nephrectomies. I do a little bit of dialysis access surgery, a little bit of general surgery. I always thought it's funny. Like, I'm not an expert in like hernia surgery or gallbladders, but we get like the cirrhotic patients that are. Anyway, if anyone wants to take over that practice, I think it's up to the So fast forward. Okay, so this I just kind of wanted to show like my current state of affairs here. So these are my 3 brothers now grown, and my mom, and then I have 4 little nephews as well. These 2 live out in San Francisco. These 2 are up in Arlington. I have a 5th nephew on the way in December. I can't seem to get a niece, and I think that this is like the last of the nephews. I work with these 4 jokers here at work. So I have a lot of Y chromosomes in my life, I guess what I would say. I myself am a childless dog lady, as some might call me. This is Dory and Nemo. These are my 2 babies. So, all right, so that is a little bit about me and my journey here. Now we'll get into the actual meat of the grand rounds. So when I was trying to figure out what to talk about a couple months ago when I got asked to give grand rounds, you know, I wasn't really sure. Like, a lot of people talk about their research, and I haven't really done any research since I've been here. And, you know, another common thing, I guess, a lot of people talk about, like, some topic in their field. I didn't really think everyone was that interested in some like niche kidney transplant topic. So I kind of thought about like, what have I accomplished since I've been here, that I'm proud of, and kind of what have I done? And I would say the biggest thing that came to mind was learning robotic surgery and taking over the living donor kidney transplant program after Dr. Overholzer left. And so given that probably everyone in here already has or will in their career have to learn a new technology or surgery or, procedure during the course of their career, I thought, I could talk about kind of my experience learning robotics and what are some of the relevant issues to consider. So just as an outline, talk a little bit about the historical perspective, how innovation kind of diffuses. We'll talk a little bit about how one goes about learning a new procedure, the learning curve, and ethical considerations. This is like not even remotely by any means an exhaustive list, but just some examples of major surgical innovations, in the last 50 years. Things like laparoscopy, robotics, endoscopic surgery, fetal surgery, ECMO, and these are things that like we kind of routinely practice now and think of as just, maybe as younger folks, like things that have always been around, but these are all major innovations in our field. And in the field of transplant, when I think of like the major current innovations related to the surgical side of things, I think about things like the introduction of robotics, organ pumps, like to preserve organs for longer, particularly the new liver pumps, that can be used potentially to rehabilitate organs as well. Normothermic regional perfusion, this is a new surgical technique of procuring DCD donors to kind of improve outcomes. Xenotransplant has come on the scene recently. And so there are just a million examples in surgery of surgical innovation. And when we kind of look at the historical perspective with regards to kind of minimally invasive surgery, the concept was kind of first introduced, I guess, around 1901 by this guy Kelling in Germany, who put a scope into the peritoneal cavity of a dog, and this was like the first laparoscopy. And then there was a relatively long period where this wasn't really applied much to clinical practice, maybe a little bit in a diagnostic way, but not necessarily an interventional way. And this was largely because like the technology needed to catch up with the concept of laparoscopy, like having a camera that could project the image onto a screen, having appropriate instruments, insufflation, stuff like that. And the first laparoscopic appendectomy was done by Kurt Sem in Germany in 1980. He was a gynecologist, and when he did this, supposedly his colleagues said that only a person with brain damage would do a laparoscopic surgery, and they ordered him to undergo a brain scan. I don't know if this is true or not, but the early criticism, the early comments about laparoscopic surgery was that it's this like futureless technique. It's not going to go anywhere. It's dangerous. It's unethical. And it just should not be embraced. In 1987, I read by the way, there's kind of the year and the person that did the first lap chole, a little sketchy in the literature, but 1987, this was probably the most common report I came across. Philippe Moret, I'm sure I butchered that, did the first lap chole in France, and very rapidly this technology and technique diffused in a way that is kind of unique, honestly. Within just 3 or 4 years, there was like a 70% adoption rate of laparoscopic cholecystectomy, which is just, if you look at adoption curves of other minimally invasive procedures, it's just rapid uptake of this procedure. Interestingly, when I kind of think about this in historical context, this kind of blows my mind. The first laparoscopic donor nephrectomy was done in 1995 by Lloyd Ratner. He works up at Columbia. And the reason this kind of blows my mind is donor nephrectomy, it's the surgery most amenable to minimally invasive techniques in the field of transplant, but it's also the surgery that's kind of held to the absolute highest standard of minimizing risk and, you know, low tolerance of complications, because these are people who do not need surgery. They're undergoing, you know, a surgery to help someone else. And so the leap of kind of converting from an open procedure to laparoscopy within only 8 years of when it had been introduced for cholecystectomy is pretty remarkable to me. In 2000, the Da Vinci robot was approved. 2001 is when the first reports of the robot being used for donor nephrectomy came out. And, you know, obviously we've seen an uptake in this stuff since. Not to make anyone feel old or young for that matter, but I came along in this era. So focusing on laparoscopic cholecystectomy, I mentioned kind of the rapid diffusion of this technique, but that came along with, you know, some criticism and side effects, I guess, if you will, that were maybe not recognized for several years. And this has been like used in the literature over and over since then as an example of taking pause, maybe have, you know, approaching the implementation of a new technology with some degree of thoughtfulness and review of outcomes and informed consent and all this stuff. So, you know, as we all know, it kind of was recognized at some point that there was a much higher incidence of common bile duct injury with the laparoscopic approach compared to open. And this was not appreciated in the early randomized controlled trials because the N was just too small. They weren't powered to detect these differences. This was one of the first major reports that drew attention to this. Interestingly, it's funny to me, like the literature since, like the literature in hindsight holds this up as like the paper that discovered that, you know, laparoscopic cholecystectomy wasn't totally safe. But like reading this paper, which by the way, I saw the asterisk, Dr. Shermer was in the Southern Surgeons Club at the time and part of this series. Like actually the paper kind of highlights what a great technique this was, how many fewer other complications there were, how much less pain patients have, return to work, all this stuff. And it was actually kind of felt like, you know, the risk benefit trade-off probably was actually still favorable for laparoscopic cholecystectomy. But this was criticized in the media also. This is an article from the New York Times in 1991, you know, like when patient's life is price of learning a new surgery. There was actually New York State put a moratorium at one point on laparoscopic cholecystectomy when these reports first started coming out. So, you know, given that there's some risk involved with learning and developing a new procedure, why would anyone bother to do this? And really the main reason, which seems pretty obvious, is the potential to improve clinical outcomes. You know, when we think about like why would we bother to learn a new procedure, you know, take on that risk, et cetera, potentially expose patients to more risk early on, it's with the goal of reducing morbidity, mortality, whether like shortens length of stay, less pain, less blood loss, early return to work. You know, other potential motivators for an individual surgeon taking on a new procedure might be things like to stay current, patient demand, peer influence, efficiency, cost, you know, for the sake of innovation itself. And, you know, to be honest, the first time I got zero exposure to robotics in residency. Like at the very end of my residency, there were a few robotics cases, but like as chief residents, we avoided those. Like we didn't want anything to do with standing at the bedside for 12 hours. So, so I had gotten zero exposure to robotics, and I first started hearing about robotic kidney transplant during my fellowship, and I thought, like, that's completely insane. Why would anyone do that? It must take forever to sew the kidney in. It's just baking in the body while you're sewing it in. You know, people go into transplant because they like open surgery, sewing, all this stuff. Like I thought there's no future for robotics in transplant. But and even when I started thinking about learning robotics for donor, like eventually came around and thought I want to learn robotics for the sake of doing transplant, but I didn't really think there was going to be any benefit for donor nephrectomy. I had been trained to do donor nephrectomy laparoscopically during my fellowship, and from what I could tell, we got pretty good outcomes. You know, the patients did well. It was a very reasonable procedure. And when you look at the incisions you're going to make and everything for a robotic case, it's the same as for a laparoscopic case. So it's not like we're converting this to a minimally invasive surgery. So I was totally not sold on the benefit of robotics for donor nephrectomy. I just saw that as a means of learning robotics to get to my ultimate goal of doing robotic kidney transplant. So that's kind of like on an individual level, what does one consider when embracing a new technology? But people have looked at like factors on a broader level, on a health system level, an environmental level of what kind of predicts the diffusion or uptake of new health innovations. This comes from like the area of implementation science, and it's been kind of categorized in different ways. This review categorized it into like innovation-based, so factors related to the technology itself. Are there improved outcomes and efficiency with this technique? Is it cost effective? Is there education and training available? Do you have adequate volume of cases to do this new technology? Organizational factors are things like, will the hospital benefit? Does the hospital support it? Is there a culture that would embrace new innovation? On patient level factors, like are patients demanding this new procedure? Provider level, the benefit to the surgeon themselves, maybe improved ergonomics, more referrals, an improved reputation or profile. And then the structural components, such as educational support, research support, policies in place to support. And it's really this kind of complex interplay of all these variables that kind of determine if a new innovation will really diffuse over time. Another way of looking at this is, looking at the three kind of determinants of behavior: capability, opportunity, and motivation, and the various domains within each of those that either facilitate or act as barriers for the diffusion of technology. And when you're talking about capability, you're kind of talking about the individual surgeon largely. Are they aware of a new innovation that needs to be implemented? Is there a strong evidence base? Are they inexperienced? Might be a barrier. What is the opportunity? And this kind of refers to the social influences, like the extrinsic factors, the environmental context, the resources available. And again, these can either act as facilitators or barriers for adoption. And then motivation kind of refers to ones like, what energizes someone, what are their habits, what are the emotional responses to a new technique. So things like reinforcement, beliefs, and consequences. And interestingly, in this systematic review, like all the literature on this topic, like the factors that kind of seem to have the most impact on the uptake of new technology and procedures are kind of in this opportunity domain. When we look at how new technology or innovation diffuses, it's kind of been described as this S curve. And early on, you have the innovators, and then you have the early adopters. So this gets you up to, somewhere around 15 to 20% of people using the technology. And then somewhere around 10 to 20% of adoption, there's described as this tipping point where the rate of adoption of this new innovation rapidly increases. You have the early majority, the late majority, and then the laggards. I love that term. So the best I can tell for the surgery that I mostly do robotically, donor nephrectomy, were, either in the innovator, I think more likely in the early adopter phase right now. Shockingly, SRTR, which reports on all outcomes related to transplant, does not track robotic versus laparoscopic cases right now. And so about 60% of donor nephrectomies are done laparoscopic hand assist. I assume most people are not doing robotic laparoscopic hand assist. Maybe some are, I don't know, but which leaves only 40% being done laparoscopically. I really think the majority of those are pure laparoscopic. So I think we're still in this early phase for robotics on donor nephrectomy. And even as recently as February of this year, I saw a news broadcast of a hospital, major academic center out in Pennsylvania, UPMC, that did their first robotic donor nephrectomy. So apparently this is still newsworthy even this year. So once you've decided, to hop on the curve here, the question becomes, what are kind of best practices to learning a new surgical technique? And, some of these things I think are pretty obvious, but this was a survey that was sent to 150 surgeons at a couple major academic medical centers in the Midwest, Michigan and Wisconsin. But it included a variety of surgeons, general surgeons, thoracic surgeons, colorectal, vascular, peds, transplant, MIS, surgeon. And they asked, what learning modalities do you think people should use to learn a new surgical technique? And one interesting thing here I thought is 98% of people have reported already in their career, and they showed the breakdown of how long people have been in practice. Some of them were 0 to 3 years, early career. But 98% of people had already had to learn a new procedure or technology as after the completion of their formal training. And people mostly reported, using things like self-directed study, didactics with simulation or cadaver lab, scrubbing in cases with another surgeon, using a proctor, or performing a mini fellowship. And then when they asked people to report what single method you use most commonly versus what you feel is most effective, they found there's some discrepancy here. So the most commonly used approaches were just self-directed study and scrubbing in cases with another surgeon. But most people felt actually probably those were the most commonly used methods. People felt the most effective methods would be, scrubbing with a partner, having a proctor, or doing a mini fellowship. And, this kind of, I think, just reflects the reality of trying to gain new skills after formal training. When they kind of tried to investigate what are the barriers of using these best practices for learning a new technique, it's not surprisingly time. The biggest factor is the time requirement that would be necessary. And a close second was confidence that you could safely implement this new technique without going through this more extensive training. Certainly there have been descriptive studies showing that the more comprehensive of a training modality people use, the more likely they are to actually adopt that technology going forward, as opposed to, say, participating in a weekend course, a one-day thing, something like that. Probably there's serious selection bias there. If you're gonna take the time to commit to learning put in a major time commitment to learning something, I think you're probably gonna be more committed to actually utilizing it. SAGES has published some guidelines. These are very general guidelines on things to consider when adopting a new device or procedure. And importantly, they really kind of tried to define, obviously all new technology is not the same. Some things are just a modification of something we're already using. So maybe a new stapler or a new mesh, something like that. Some are a completely new device entirely. So this might be the robot itself, if you hadn't used the robot. A modified procedure would be someone who is trying to learn a procedure, similar technique, but it's a new operation. So maybe going from a laparoscopic gastric bypass to learning a laparoscopic sleeve gastrectomy. And then a new procedure entirely would be a novel technique. So if you have experience with an open operation, converting that to a minimally invasive approach. And not surprisingly, people felt that, the guidelines kind of reflect this. If you're using a new device or learning a new procedure entirely, more kind of resources and approaches should be used to effectively learn that technique. So how did I go about it? Intuitive does kind of lay out, and I'm learning in my case, I was learning a technique that's already pretty well established. There's 24 years now of use of the Da Vinci robot, and so some of these kind of training pathways are in place, but essentially it involves doing some online modules. I know the residents are familiar with this. You do these online modules, watch these videos, practice on the simulator. There are kind of various tasks you have to demonstrate that you can perform on the simulator. And then, luckily, when I was learning this, Dr. Oberholzer was still here, but you know, I scrubbed into several of his cases, watched how he did it, learned the general approaches, learned the bedside portion of the procedure. And then I did I mean, I don't even know how many, probably 20 skills sessions where I met with Shane, the intuitive rep that we worked with. He's moved on now, but, you know, in the OR at 7 p.m. on a weeknight, like practicing with the robot on the little practice simulator thing, like basic skills, moving the camera, you know, passing the little piece of paper, doing the little ring exercise. And then you go to this one day, it's like a half day really session at one of the intuitive training sites, where you have a proctor, and then, you know, and then you do 3 proctor cases and good to go. So I did, after my training, continue to have Jose around for, I don't know, probably another 3 or 4 cases. And then one day he was like, all right, I think you're good. And I launched off on my own. So learning a new technique, one of the main issues here is the learning curve. And this is probably the critical part of learning a new surgery. The learning curve is essentially the rate of progress in gaining experience or new skills. And it's usually described kind of like until you reach a plateau. Now, one thing to say about the plateau, just because you've reached a plateau doesn't necessarily equate to high quality. It just means that maybe the surgeon's no longer improving on that new procedure. It's usually measured as a change in an operative variable. This variable is used as like a surrogate for surgeon performance, so things such as operative time, complications, length of stay. And you know, the reality of this is you have less than perfect outcomes early in the learning curve because you don't have the experience yet with the procedure. And the learning curve, like as it pertains to learning a new procedure post formal training, it's really in stark contrast to residency where you're supervised, you kind of get graduated responsibility. So we talk about the learning curve a little bit less in residency training than learning a new skill once you're kind of granted privileges to perform that skill. And obviously it's really important to like navigate the learning curve, try to minimize it as much as, or shorten it as much as possible to minimize patient harm. This was a systematic review that looked at specifically in robotics, what metrics are used to kind of define the learning curve and what are robotic learning curves. And most studies, this included 68 studies in the literature as of 2020, most studies use some sort of time variable. You know, time is, it's one variable. I think it's it's imperfect for many reasons, but the most common thing by far, operative time, you know, the time it takes to do some specific part of the procedure, console time, docking time, stuff like this. Others use, you know, complication rates, like I mentioned, maybe procedure specific things. And in this systematic review of how many cases the learning curve takes in robotics, it ranged from 0 to over 400. I have bad news for the cardiac surgeons in the room. The cardiac cases were the ones that are like over 400, like robotic mitral valve replacement or repair. I'm not sure what you guys do robotically, but yeah, good luck. So this is data that's captured like in the intuitive app and online website. You can kind of look at what is your own learning curve with a new procedure. And for the most part, I just included donor nephrectomy here. That's the majority of the robotic cases I've done. I've done like 3 cholecystectomies, I think. But it's a little hard to know what to make of this. So this is just time, how long it takes to do the case. I can say my first 1 to 10, these were all cases I was on the console next to Jose, and he did some or all of the case. So probably just should exclude those from my curve. And then, 11 to 25 cases here. I'm way slower than the U.S. average. That's the line down here. And I got slower somehow as I did, more cases. And then now just recently I've started getting a little faster. I think it's a little hard to know what to make of this. First of all, I will say I'm not a speedy surgeon for anyone that's followed me in the OR. And I'm guessing that if you looked at my time compared to the national average for most operations I do, it probably would be slower than average. But and then the other confounding issue here is training. We train fellows, and so there's some variation in how much time was spent there. But I think another way of looking at this is my distribution of times for the case, and maybe one way of thinking of my learning curve is, this was about, 6 months into doing these independently. You can see my variation and how long it's taking me to do them is a lot tighter. So at least I'm more consistent. So maybe if we use consistency as a measure, I'm past my learning curve. I don't know. We'll see. It's a little hard to use complications for donor nephrectomy as the learning curve for two reasons for me. One, I don't have a historical comparator for myself of rates of complications doing this laparoscopically, aside from my fellowship experience. And the overall rate of complications for donor nephrectomy is extremely low. So it's hard to use that metric, but looking at length of stay, I went back and looked at our length of stay, which is the blue line here for donors ever since for the last 4 years. And I came in August, somewhere in here, August 2022, and started doing these somewhere around here. So there was a slight increase in our length of stay, maybe over my first 6-month experience. Again, it's a little hard to know what to make of this, but maybe one could say my learning curve was a period of time and it started to downturn slightly. In trying to be very transparent to myself and honest with myself, what are the complications or things that have happened in my series of 64 donor nephrectomies, I started listing all the complications I haven't had, but then I was no, I'm gonna curse myself, so I took those off. But if it's not listed here, it's not a complication I've had yet. But the 4 issues I've had in my 64 donor nephrectomies, there was a stapler misfire, which interestingly was a laparoscopic stapler that misfired when I had actually converted from doing the case robotically to a hand assist fashion. Victor knows about this. He came and helped save me from it. I think the whole OR actually knew about this. It was very stressful. I had one colon serosal tear, which was from introducing a laparoscopic clip through our fan and seal port. And since then, I've now converted to using the robotic clip because of that. So I don't think that was necessarily a robotic issue, although one could argue your field of view is different on the robot. So that could be a contributing issue. I had one pneumothorax in a guy who had a congenital diaphragmatic hernia repair of his left diaphragm as a baby, and we were doing a left nephrectomy. When I was trying to mobilize the spleen, I made a little defect in the diaphragm, and he essentially had a subclinical pneumothorax. He didn't require any intervention and didn't need oxygen, didn't have any symptoms. And then we just had our first incisional hernia at the fan and seal incision. So that's my series here. And when I compare that to the literature of, what is the learning curve in the literature and how does robotic compare to laparoscopic, looking at the biggest meta-analysis, most recent also including a series of donor nephrectomies. This included 17 studies with close to 7,000 patients. They found that experienced surgeons doing robotic donor nephrectomy, which they found in most studies was somewhere around 20 to 25 cases, people actually had better outcomes compared to either experienced, so the line here is experienced laparoscopic donor nephrectomy surgeons or inexperienced laparoscopic. So lower conversion rates to open for experienced robotics, shorter operative time, and overall fewer complications in the robotic group. So the conclusion from this was that robotic donor nephrectomy is a superior operation after completion of the learning curve. this gets us to kind of the final area of consideration, ethical considerations. The big issues here are really, how is safety ensured for patients? You know, how should new technology be introduced and implemented? How are patients informed? What is the consent process? You know, how are surgeons credentialed to be doing these new procedures? And then how are outcomes tracked and evaluated over time? And how do we balance our responsibility to the individual patient in front of us with our, you know, with society at large? Obviously, the reason to introduce this new technology is to improve outcomes for patients in the future, but that means the patient in front of you that day, maybe on your learning curve, is paying some sort of a higher price for that. And when we consider ethical issues, you know, we kind of need to think about where surgical innovation falls on the spectrum of regulation and the spectrum between what constitutes practice and research. The Belmont report was the report published in the late 1970s outlining, you know, ethical principles and guidelines for the management of human subjects research. And it defines practice, like just routine medical practice, as interventions designed solely to enhance the well-being of an individual patient with a reasonable expectation of success. And then on the other end of the spectrum is research, an activity designed to test a hypothesis. You know, it's described in a formal protocol with an objective and a set of procedures. And you know, surgical innovation really kind of falls in this wide area between routine established practice and research. And where that line is exactly is not easy to define. You know, if like every day we're in the operating room, we're innovating to some extent. You set up your retractor a little differently, maybe like use a slightly different suturing technique. I don't know. I mean, there's all sorts of ways we innovate every day in the operating room with the purpose of just trying to provide the best outcome for that specific patient. And, you know, you can imagine like something like a new stapler or a new approach kind of fall more in the middle, an entirely new operation, you know, maybe is bordering on research, maybe falls under research, might be regulated by an IRB, but still could just be in the realm of surgical innovation. I thought this diagram kind of shows where innovation lies in this gray zone between the two areas that are highly regulated. And so new devices, when introduced, are heavily regulated and overseen by the FDA, in theory. Research is kind of overseen by IRBs, you know, under the common rule, heavily regulated. And then in this area between, where you're either modifying a device using a device off-label or making some other innovative change, it falls in this kind of abyss of like not really much regulation. And this begs the question, like, who is responsible for credentialing and privileging new procedures? Credentialing is essentially our process that ensures that there's some degree of safety for patients when new innovation is being introduced. There's this natural tension that's going to exist between innovation and regulation or safety. And it's been pretty clearly established that individual institutions are responsible for ensuring that a surgeon has the appropriate credentials to be performing whatever they're doing, and then give them the privileges to do those procedures. And this was kind of tested out in a lawsuit in 2013. This involved a robotics case where a urologist, who's not Taylor, Taylor was the patient, a urologist did a robotic prostatectomy on a guy, and it was his third robotic prostatectomy. He had done his 2 proctored cases. This was his first non-proctored case. The case took, I guess, a very long amount of time and eventually converted to open. The guy had several complications, and this significantly impacted his quality of life and eventually led to his early demise. And because the hospital had used Intuitive's kind of pathway of training and credentialing the surgeon, this patient's the patient's attorney or family sued Intuitive, saying that they did not adequately ensure sufficient training and oversight for the surgeon to properly perform the procedure. And the jury actually found in the favor of Intuitive, setting precedent that the manufacturer of a device is not responsible for ensuring good outcomes if that device is being used inappropriately. So, i.e., by someone not fully trained or, whatever, to use it yet. And hospitals, if they do perform inadequate credentialing or privileging, can be held responsible for malpractice. So the process here at UVA for getting credentialed in robotics is essentially, ultimately kind of the credentialing process is you have to do these 3 to 5 proctored cases and get signed off. But to get to the point of doing the 3 to 5 proctored cases, you have to do Intuitive's kind of initial training scheme, which involves the online modules, the simulator exercises, and then going to the half-day consult surgeon training at one of the training sites. In addition, they offered and sponsored, skill sessions and case observations, which I did, but those are not actually required in our credentialing pathway. And so this is our credentialing form, this is our proctoring form, saying whether you're adequate or need more practice, and the little fine print down here at the bottom, you can see this is Da Vinci surgery. This is Intuitive's form. Da Vinci surgery, this is not replacements for hospital policy regarding surgical credentialing. It only trains on the use of the product. Any demonstration, it's not saying that we're recommending this or certifying you. It's the responsibility of the hospital. And when surgeons are asked if they think credentialing and privileging is adequate or not, the majority of surgeons feel that current credentialing and privileging pathways are actually too relaxed, either far too relaxed or somewhat too relaxed. And I think this highlights where the importance of professionalism and ethics come in as a surgeon. Just because we're credentialed or privileged to do something, doesn't mean we should, and maybe it means we should be seeking additional support or training before actually offering that to a patient. The last kind of issue here is informed consent. This is obviously really important, especially when you're on your learning curve or introducing a new innovation, and it's hard. Like, this is a hard thing to do properly, and there is not great guidance on exactly how or what you should discuss with patients when you're introducing new technology. The literature does seem pretty clear, like you should disclose this is a new procedure to you. If it's the first one you're doing, that's an important thing to share with the patient. You should discuss the risks and benefits, the unknown risks. Some institutions have like a new technology committee that might have some input or a separate consent form for new innovation. But definitely not an easy topic. So what does the future hold? So again, as I mentioned, the whole reason I wanted to learn robotics and started out with donor nephrectomy was to eventually get to robotic kidney transplant. And we were doing robotic kidney transplants here before Jose left. I have not started doing them. The setup essentially and the purported benefit is that you can just have a small epigastric incision in a location where someone's abdominal wall is a lot smaller compared to our traditional right lower quadrant, Gibson incision, where most people carry all of their subcutaneous tissue here. And wound morbidity, particularly in patients that are immunosuppressed, would provide a huge potential benefit for kidney transplant. And this is the experience actually at UVA from 2017 through 2021, essentially looking at our 24 robotic versus open kidney transplants that were done during that period of time in obese patients. Really, the majority of the outcomes didn't differ between the two groups. And importantly, creatinine and GFR a year out were similar between the robotic and open groups. Blood loss was a little less in the robotic group, and warm ischemic time trended towards being a little bit longer. This is how long it takes us to sew the kidney in, not surprising, a little bit longer in the robotic group. But they saw much fewer wound complications, which again, not surprising. There was a 37% incidence of infection in the open transplant group, which certainly we see, and only 8% in the robotic group. And not only does robotic kidney transplant appear to improve outcomes, but importantly, it improves access to transplant in patients with obesity. Most programs have like a BMI cutoff, and patients are literally systematically excluded from access to kidney transplant if they're in a high BMI category. A fifth of transplant centers don't even list patients with BMI greater than 40. The 32,000 living donor transplants performed in the U.S. over this time period, only 1.9% were in BMI greater than 40. So this technology is potentially a way to give access to obviously a life prolonging and quality of life enhancing intervention that this patient population just basically doesn't have access to right now. And we have a new partner joining us in a couple weeks. She has some robotic experience from residency and fellowship. I'm hoping we can partner together to take on robotic kidney transplant. And this is how you know when the talk's over, when someone puts up their picture of their babies. Thank you.
Thank you, Christy. Fantastic talk, and we appreciate you being the first pioneer as a new faculty to have a chance to introduce yourself to the whole department, and appreciate our transplant team showing up. Dr. Provenza, would you like to ask a question?
Yeah, I have actually a question. First of all, congratulations to Sean for seeing your tremendous potential in getting you here. And congratulations to the entire department for having you with us. So it's a great skill to have, and thank you for this wonderful talk. Actually, I heard with very interest quite a few points that you made. And one thing that struck to me was the most commonly used versus the most effective methods to adapt the new technology as practicing surgeons. And you mentioned that scrubbing cases performed by another surgeon and performing under proctor supervision, it appeared from the literature and from others that are the most effective methods. So my question to you is that how you incorporate these two methods within our learning, environments with the trainees that you're having every day. So how you kind of like marry these two things?
That's a great question. I'm not sure I have a great answer. That's one of the major challenges, I think, of faculty learning new procedures is, it affects the training of residents. And certainly that's why I avoided robotic cases in residency. I think, for instance, there are parts of a surgery and people are different learning curves. So for instance, when I took on learning robotic donor nephrectomy, like I was well versed in the operation itself laparoscopically, whereas maybe some of my trainees working with me aren't, that's the stage of the process that they're at in learning is like at a different part of the case. So, I think just trying to include trainees as much as possible. I don't think as a surgeon learning a new procedure, you don't necessarily need to be learning or be the one doing the suturing, for instance, or doing each part of it. I think learning robotics, obviously you need to be on the console doing it, but for various new things that one's learning, like you don't have to necessarily be doing the act of the thing, which maybe a trainee would benefit from doing. Maybe someone else is still mastering suturing or, vascular anastomosis or whatever, but being present, watching how the case is set up. So I don't know. I think that's a major challenge, obviously, of learning new techniques, but it is also just the reality of kind of pushing surgery forward also.
So Christy, tell me a little bit about your mindset for the residents coming in, it was kind of sudden change for you. You come in, you left a really good job to come to what was hopefully your dream job. You were going to learn robotics, have a great mentor who's going to teach you. And next thing you know, they're gone. And it's, all right, Chrissy, figure this out for yourself. What were you thinking at that moment?
I don't know if this is like a loaded question.
My point is.
Yeah,
that
it was
things change,
stressful.
right?
Things change, right? I mean, what are you gonna do? Like, I still wanted to learn robotics. Like, the infrastructure was still set up for me to learn robotics here. I fortunately got at least some base with Overholzer before he left. But yeah, now I have to kind of use some of the other approaches that it would have been easier if he was still here and I could just do robotic kidney transplants alongside him and learn that technique. But now it's going to be more practicing on my own, going to do case observations, maybe bringing a proctor in from the outside. We specifically targeted hiring a person with some robotic experience. But yeah, I guess make the best of the situation you find yourself in and just keep going.
Bruce?
Well, Chris, yeah, that was a great talk, and it's really great to have you back on our faculty. We're late in the hour, so I'm just going to make two observations. The first is, over the years of my career, I've been extremely impressed by most surgeons are very careful about adopting new technology. They want to do it safely, and they make sure that it is done safely. As you said, professionalism is the highest standard. The second is that, a lot of training now is done through fellowships, but there does come a time where people who are out in practice want to learn a procedure. And I think we at academic medical centers need to make ourselves available to do some of that instruction and teaching. We did in laparoscopy in the early 90s, and the surgeons in the area greatly appreciated it. And I think it certainly contributed to better outcomes and safety. But throughout your careers, if you have people that want to come and work with you and you can proctor them in a non-fellowship mode, I would encourage you to do that, because it really does promote goodwill and patient outcomes.
Charles?
I know it is late, but I just want, as we go into the recruiting season, I was going through my emails and I found something from 2008, I think it was, or 2011. I've got your letter of recommendation, which I just sent to you, but it is an incredible joy to watch the process of seeing medical students go to this. And, we've seen a lot of talks recently about the business of medicine and all this, but sometimes we forget why we're here, which is one, to take care of our patients. Second is to train our trainees. And this is what we get to, after 23 years of being here, you get to witness. So, we're going into recruiting season, so let's go find the new Chrissy Papageorge. And I won't try to be as blunt as Bruce in the future about the grass being green and all that stuff. But thank you. It's great.
Yeah, but whatever.